Good afternoon, good evening, everyone. My name is Nuri Kwon, a medical advisor from Exact Sciences. I'm delighted to welcome you to today's webinar. The title of our session is Advancing Tailored Treatment in ER-positive HER2-negative breast cancer, Clinical Insights from the 2025 St. Gallen Breast Cancer Conference. Thank you for joining us. We are very excited to share the latest evidence and expert perspective from this year's conference. This is today's agenda. Following this short introduction, we will begin with a scientific session led by Professor Hyung-gun Moon, covering key topics from the 2025 St. Gallen Conference, including genomic testing in the neoadjuvant setting, adjuvant therapy decision-making, and controversies in nodal radiation. Next, Professor Chun-Xiong Huang will present highlights of the international consensus. We will close with a short Q&A session with both speakers at the end of the webinar. Now, I'm very honored to introduce our two distinguished speakers. First, Professor Hyung-gun Moon. He is the director of the Breast Cancer Center at Seoul National University Hospital, and he is serving as the editor-in-chief of the Korean Journal of Breast Cancer. Our second speaker is Professor Chun-Xiong Huang from National Taiwan University Hospital. He is the president of the Breast Cancer Society of Taiwan and served as a panelist for the 2025 St. Gallen International Consensus. Together, they will present key updates from the conference and discuss their clinical implications for Asian patients.
Thank you. Thank you for your kind introduction. Good evening, everyone. My name is Hyung-gun Moon. I'm breast surgeon at Seoul National University Hospital in Korea. First, I'd like to thank the sponsor, Exact Science, for supporting today's webinar. And I hope today's webinar can provide our colleagues a brief insight into the very contents that were shared at the recent St. Gallen meeting. During my 30 minutes talk, I'll try to summarize some of the key talks presented at the recent meeting. And our first topic is the evolving roles of genomic testing in neoadjuvant settings. We'll take a close look at two prospective trials that provide valuable evidence on how genomic assays can be applied before the surgery using the needle biopsy samples. The first study is a prospective study conducted at Canada, led by Professor Stefan Chia. The study explores the use of Oncotype DX breast recurrence score results in guiding treatment decisions in patients who are potential candidates for neoadjuvant chemotherapy. The primary endpoint of this study was to assess the feasibility of performing the Oncotype DX testing on cold needle biopsy samples rather than the usual surgical specimens obtained after surgery, and to report the turnaround time of this testing and how it affects the time needed to initiate the systemic therapy. And also, the second objective of the study was to evaluate how the recurrence score testing results can influence the systemic treatment recommendations and overall clinical decision-making for breast cancer patients. The eligible patients were between the age of 18 and 89 and T2 or more, or clinical node positive breast cancer patients, and all patients were hormone receptor positive and HER2 negative. And they were candidates for either surgery or chemotherapy or hormonal therapy. So in this study, the average turnaround time of Oncotype DX testing was 19 days, ranging from 7 to 32 days. And for patients who received chemotherapy, the treatment started on average within 20 days, with the range of 3 to 32 days. On the left of the screen, you can see the success rate of performing Oncotype DX testing on cold needle biopsy samples. And you can see that it was successfully completed in 97% of the all cases, with only 3% experiencing some technical issues. This shows that strong feasibility of using cold needle biopsies in the neoadjuvant setting for Oncotype DX testing. On the center, we can see the baseline distribution of recurrence score results, showing that only 3% having low recurrence score less than 10, 68% showing intermediate recurrence score, and 29% showing high recurrence score higher than 26. The distribution shown in this study is consistent with what we see in our real-world practice for our early breast cancer patients. Now, the right panel shows the impact of recurrence score on treatment decisions. First, Among the patients whom neoadjuvant chemotherapy was initially planned, 64% were found to have a recurrence score less than 26, and 44% among them had their treatment plans changed. Rather than staying with neoadjuvant cytotoxic chemotherapy, their plans were changed to either surgery or neoadjuvant endocrine therapy. On the other hand, 26% of patients who were initially recommended for upfront surgery had a recurrence score higher than 26, and neoadjuvant systemic chemotherapy were recommended for these patients. And half of the patients who took the recommendation and underwent neoadjuvant systemic chemotherapy rather than undergoing upfront surgery. So in conclusion, preoperative use of the recurrence score from needle biopsy samples can offer a meaningful clinical guidance both in determining the potential benefit of chemotherapy and in informing the sequence of therapy. These results suggest that genomic testing can play an important role in planning overall treatment plan in hormone receptor positive, HER2 negative breast cancer patients. Now let me now introduce the PRE-DX study from the UK, which was presented by Dr. Henry Kane. This study also evaluated the clinical impact of moving Oncotype DX testing earlier in the treatment pathway, specifically in the preoperative setting, to assess how this change may influence the management of the breast cancer patients. PRE-DX was a multi-center prospective randomized control trial using a 2-to-1 randomization design. Patients in the intervention arm received preoperative Oncotype DX testing using the needle biopsy samples, while those in the control groups used the usual conventional surgical samples for the testing. And this study also demonstrates that a very high Oncotype DX success rate, which was 29.2%, emphasizing the feasibility of performing Oncotype DX testing using the needle biopsy samples. The primary outcome was the number of clinical appointments from diagnosis to the offer of adjuvant therapy. Interestingly, the study did not find statistically significant differences between the groups. However, as this trial was conducted during the COVID-19 pandemic, this finding may not reflect the day-to-day practice in the real world. And only a small proportion of patients had changes in the treatment sequencing, with 3.5% in the intervention arm and 2.6% in the control group, showing that most of the patients were managed by their initial treatment plan. Now here we see the median time intervals according to the different stages of the treatment pathway. Across all comparisons, the intervention group consistently showed a shorter timeline, but it did not reach the statistical significance. In all timeline milestones, the intervention group, who had earlier testing of Oncotype DX using the needle biopsy sample, showed numerically low time interval of 7 to 9 days, but again, it was not statistically significant. This suggests that there might be a trend toward the time efficiency with preoperative testing, but further studies are needed to confirm this finding. Next, we'll look at how preoperative testing impacted patients' emotional well-being. This slide shows the results for patient-reported anxiety and depression assessed using the HADS score. Patients in the intervention group, those who received Oncotype DX testing preoperatively, reported significantly lower depression score, averaging 4.1 compared to 5.2 in the control group. This difference was statistically significant. Similarly, the overall HADS score, combining both anxiety and depression, was 10.2 in the intervention group, while it was 11.5 in the control group, which was also statistically significant. These data suggest that providing genomic information earlier in the treatment process may help reduce emotional distress in breast cancer patients, and this was likely by enabling earlier decision-making and more clear communication with our patients. To summarize the finding from the PRE-DX study, preoperative Oncotype DX testing was feasible and reliable with a 98.2% success rate using the core biopsy samples. There was no significant difference in numbers of clinical visits overall, and but we saw overall non-significant, but there's a evident trend toward shorter treatment timelines in the intervention group. Importantly, there was a significantly significantly better emotional distress in patients who receive preoperative oncotype DX testing. And when these findings are taken together, these results suggest that when implemented under normal conditions, preoperative genomic testing has the potential to streamline care and improve the patient's experience. So in the next session, I'll cover the topics on more broad scopes of adjuvant therapy in hormone receptor positive HER2 negative breast cancer patients, including the decision-making for chemotherapy and CDK4/6 inhibitors. First, I'll introduce this slide. Dr. David Cameron shared his view on the use of adjuvant CDK4/6 inhibitors under the title of Crawling Toward Cure, Small Steps of Clinical Benefit in Hormone Receptor Positive Breast Cancer. In his talk, he raised an important key question, which is, will CDK4/6 inhibitors lead to more cures in hormone receptor positive disease? He points out that historically, the biggest gain in cure came with tamoxifen, and later the use of aromatase inhibitors added further benefit, but which was smaller than tamoxifen. And when it gets to the CDK4/6 inhibitor, this is where the things get a bit more complicated. As it points out, these agents are not uniformly available in many of the worlds, and even though even in countries where these trials are conducted, so it's really very difficult to investigate the real-world outcome data. He also raised concern that, which is what we see in clinical practice, what happens after the patient's disease progress on CDK4/6 inhibitors. In the metastatic setting, second-line endocrine therapy often reduced efficacy in these patients. And he specifically highlighted data from the Emerald trial in which all participants received prior CDK4/6 inhibitors. As you can see in these slides, the median progression-free survival was only 3.8 months. This finding raises a concern whether using CDK4/6 inhibitors in the early setting could actually reduce the effectiveness of subsequent endocrine therapy in the metastatic setting. And the issue is surely an area of active research focus now. Dr. Cameron shares his personal views on the real-world approach to the adjuvant CDK4/6 inhibitors. He does offer it to eligible patients, but with full transparency. He clearly tells them that there's no solid evidence of overall survival benefit, and he restricts its use to patients with a substantial residual risk of recurrence, which might be more than 16%. He also makes sure to inform the patients about the potential toxicity burden during the 2 years of treatment. Surely the use of adjuvant CDK4/6 inhibitor is not a one-sided decision. It's about making a joint decision in the face of clinical uncertainty. And that brings us to his key takeaway. Shared decision-making is essential given the lack of definitive survival benefit and the potential for long-term toxicity. Now, what about chemotherapy? Dr. Kolensky shares his insight on the use of anthracycline-based chemotherapy based on their exploratory analysis of TELRX trial, which was also presented at the San Antonio Breast Cancer Symposium. In patients who had recurrence score higher than 31 or tumors larger than 2 centimeters, they observed statistically significant benefit with the use of anthracycline for their adjuvant chemotherapy. In this group, the anthracycline-based chemotherapy conferred additional benefit regardless of menopausal status, with comparable magnitude of benefit in both pre- and postmenopausal patients. It's important to note that, however, this was before the integration of CDK4/6 inhibitors in the adjuvant setting. During his talk, Dr. Kalinsky offered a practical summary to the questions: which ER-positive patients still require chemotherapy? While this remains an open and individualized question, his personal guiding principle was the absolute benefit of at least 5%. For node-negative patients of any age, a recurrence score over 30, or high clinical or genomic risk, such as high-risk mammaprint, should consider chemotherapy, especially when tumor size exceeds 2 centimeters. In younger patients, especially patients younger than 50 years of age, even a recurrence score of 21 or higher might warrant further discussion. In node-positive disease, he stressed that premenopausal status alone should not be automatically trigger chemotherapy. Genomic testing still remains helpful, not only for prognosis, but also to guide decisions around ovarian suppression or CDK4/6 inhibitors. For postmenopausal patients, factors such as T3 tumors or more than 3 lymph nodes involved may still justify chemotherapy. So until more data becomes available, clinical judgment remains essential. The last topic is the use of nodal radiation in node-positive breast cancer patients. This session featured with a structured debate with 4 experts panelists who argued in favor of regional nodal irradiation, while the other 2 presented evidence against the RNI. Each speaker brought data to support their position, focusing on survival, toxicity, and risk stratification. And at the end, a live audience vote was conducted, reflecting how divided clinical opinions still are on this important issue. Let's look at the argument in favor of regional nodal irradiation, which was presented by Dr. Potter and Dr. Kaida-Person. First, they emphasized that axillary dissection de-escalation trials like C0011, IBCSG23001, and Sinomac were conducted in the context of whole breast irradiation, often including high consents. This means that many patients still receive some nodal coverage in terms of radiation. So these trials don't prove it's safe to omit both ALND and RNI. Second, the DBCG-IMN2 study showed that even with modern systemic therapy, including chemotherapy and endocrine therapy, patients still benefit from regional nodal irradiation with the hazard ratio for mortality 0.84, indicating that there are certainly added benefits from regional nodal irradiation. Third, they pointed out a gap between what's prescribed and what's actually delivered in the patients who participated in the clinical trial. Quality assurance data from BOZ and INSEMA trial revealed that intended nodal doses were frequently poorly controlled. For example, in BOZ, only 60% of the prescribed dose reached the level 1 axilla. This raised concern about the reliability of the escalation without the verified RNI delivery. Fourth, many low-burden nodal trials lacked RNI quality assurance. Trials like Z0011 and Amaros trial, they didn't have this protocolized RNI or central QA review, which limits how confidently we can apply those findings to our daily practice. Lastly, RNI remains the standard of care, at least for now, until the future more evidence such as PASAP trial can give us other directions. Now let's review the arguments against routine use of RNI for all node-positive low-volume breast cancer patients. Dr. Monica Morrow and Dr. Kurtzmans argued that the benefits of RNI is modest and not universal. In MA20 and EORTC 22922, only small gains in disease-free survival was seen, and there was no clear benefit in ER-positive or single-node positive patients. Second, with today's effective systemic therapy, local regional recurrence rate is pretty low, often lower than 2%. In hormone receptor positive and HER2 negative patients treated with endocrine therapy with or without chemotherapy. This was shown in trials like RESPONDER and NSABP-B28. Third, the genomic tools now allow us to accurately stratify recurrence risk, which means that patients with low oncotype score can have a low local recurrence risk even without RNI, supporting a more selective approach. This was also supported by, they also pointed out that the EBC-TCG post-mastectomy radiation meta-analysis, which is often the basis to support the RNI, is now outdated. It was based on older trial data without modern subtype classification and systemic treatment. Finally, toxicity risks from RNI are real. In EORTC and DBCG cohorts, increased cardiac and pulmonary toxicities have been commonly documented, especially when internal mammary nodes are treated. For all these reasons, they concluded that RNI should not be applied universally, but rather be tailored based on the risk and the benefits. In the post-debate audience vote, 52% of participants opposed the universal application of regional nodal irradiation for all patients with node-positive, low-volume breast cancer patients, compared to 46% in favor of applying routine RNI. Although the vote was narrowly split, these results reflect a more prevailing inclination toward the more individualized approach for RNI rather than its routine use in all patients. Also, this close margin of voting results also highlights the ongoing controversy and need for further evidence from more prospective trials such as PASNAC trial. Before I close this section, I'd like to remind everyone that while integrating recurrence score into the decision-making of adding RNI, it seems promising based on the exploratory analysis of our RxBond trial. The Oncotype DX recurrence score has not been validated to guide such decisions. Thank you.
It's my pleasure to have the chance to talk to you about what I feel about the St. Gallen consensus this year. I think it's my privilege to be in the panel since 2017 till 2017 till now, and it's been 5 times, and it's really a pleasure to join the discussion. And excuse me, I cannot advance the. I cannot. Oh, okay, now. So, okay, let's start to discuss about some consensus this year. The first question is that is radiation therapy needed after mastectomy in low genomic but no positive breast cancer patients? First of all, I think today we are only focused on hormone receptor positive and HER2 negative breast cancer. So if I did not mention, it's all hormone receptor positive and HER2 negative. So this is a 41 years old patient with low to intermediate genomic risk, and 1 of 3 positive node after mastectomy. So when the panel was asked about what kind of radiation therapy would be appropriate after mastectomy, the panel was actually evenly split. That's 47% recommended no radiation, and another 47% chose chest wall and regional nodal radiation. So this result reflects that there is a lack of consensus in managing patients with low volume nodal disease and favorable biology, as indicated by the low genomic risk. And this also highlights the uncertainty around integrating genomic risk into the radiation decision. And I think Dr. Moon also pointed out just now. So, okay, so let's move to the second question. When to offer the chemotherapy in ER-positive disease. The panel was asked about whether the benefit of distant disease-free survival is 5% or more or 10% or more when will you offer adjuvant chemotherapy. To me, I think the difficulty is how do you know the distant disease-free survival is about 5% or 10%. Before we have adjuvant online to tell us, you can calculate while inputting the tumor size, lymph node number, and ER status, etc. But now you don't have adjuvant online. Instead, you have predict. But if you go on to predict, you find out there is no distant disease-free survival, but instead there is overall survival. So, but maybe it's close. But anyway, you need to calculate, and then you decide whether or not to offer the adjuvant chemotherapy. And the panel and also the audience, they also vote. And most of the groups respond about similarly, that 63% 63% or 65% of the group agree that if the DDFS is about 5% or more, they will offer adjuvant chemotherapy. So then the panel was asked that when will you order an genomic assay? If the tumor is smaller than 1 centimeter, will you consider order a genomic assay in a non-negative patient? You can see that about 61 or 62% of the panels say they will not order genomic assay. I think this is probably because that in previous study like NSABP 21, the risk of distant recurrence in a tumor smaller than 1 centimeter and no negative is quite low. So that's why most of the panels agree that it's not necessary to order genomic tests. But still, you see, 38% of the panels still will consider order a genomic assay, even the tumor is smaller than 1 centimeter. So the tumor threshold, the tumor size threshold for genomic testing is for if the tumor was larger than 1 centimeter, I think most of the panel agree, 100%. But when the tumor was smaller than 1 centimeter, probably only 1/3 of panel will agree, and they were between 0.5 centimeter to 0.9 centimeter. So this is something for you to think about it when you are going to order a genomic test. So the question is, the question asks whether you will order genomic test before surgery to decide whether or not to offer neoadjuvant chemotherapy or neoadjuvant hormonal therapy, or you will proceed to mastectomy, then you will decide later. I think you can see that about 37% of the panel think they will proceed to mastectomy. Systemic treatment is unlikely to affect the surgical outcome. And I forget to tell you that this is a T3N1, clinically diagnosis, but this is a grade 1 tumor. So maybe the tumor is relatively large and you have positive node, but this is a grade 1 tumor. Will you consider order genomic test before you're doing the mastectomy so that you can decide whether you want a neoadjuvant chemotherapy or neoadjuvant hormonal therapy? Or you prefer to do surgery first and then probably later on you will order a genomic test to decide whether you want offer adjuvant chemotherapy or not. So it seems that some about 1/3 of panel think it's better to do surgery first and then do the genomic test later. But still, the other panels think that they will probably go ahead to offer neoadjuvant endocrine therapy as this is a grade 1 tumor, and the other panels consider that T3 and N1, so it's probably you need chemotherapy for the downstaging. And so these are all the choices that the panel will think about it. So this is quite varied among the panel as their decision. So now, if you order the genomic test and this confirms is a low risk signature, this is a low risk genomic tumor, then what will you do next? Still, half of the group will consider surgery first, but some will think that since this is a low risk tumor and it's okay to go ahead to do a neoadjuvant endocrine therapy. I will confess that I'm not a big fan of neoadjuvant endocrine therapy because you will not let you will know why I'm not, because the following question is going to ask a very interesting question that I frequently ask myself. But for this one, if you have a genomic test before surgery and you find out this is a low-risk tumor, I think neoadjuvant endocrine therapy is a choice if the patient decides she has the need of downstaging either tumor or the etc. But to go ahead to do surgery is, of course, another option. So if you have done neoadjuvant hormonal therapy, because this is a low risk by genomic test, and after 6 months, maybe you do surgery and you still find residual tumor and also 3 positive nodes, what will you do? Will you consider adjuvant chemotherapy? Let's see on the left-hand side, that's the vote from the panels. You see, it's completely split. 50% agree that no need of chemotherapy, but 50% of the panel will offer chemotherapy. And so I say this is a question that I frequently ask myself. But actually, if you order a genomic test, if the genomic test, especially if this is Oncotype DX recurrence score, it tells you the benefit of chemotherapy. So if it's low risk, and that means the low recurrence score, that means the benefit from chemotherapy is actually quite low. So that's why you offer neoadjuvant hormonal therapy. And then after 6 months of neoadjuvant hormonal therapy, although there is still residual tumor and even positive node, I don't think the chemotherapy will give patient any good. So there is actually no need, to my opinion, there is no need to offer chemotherapy if you have a test before showing that this is a low recurrence score tumor. But of course, not everyone agree with me. So still, some people still thinking that it's better to offer chemotherapy. And even for the audience, I think more from the audience support to offer chemotherapy. So can we telling the duration of endocrine therapy by using the genomic risk or the nodal status? So what's the panel think about the duration of the therapy related to the nodal status and genomic risk? As you know, the EBC-TCG meta-analysis published in New England Journal of Medicine shows that risk of recurrence remains high after completion of endocrine therapy, and tumor size and nodal status remain the major determinants of absolute risk of recurrence and death for these patients. So therefore, in the first case, ER positive with 1 positive node, most panels, 70%, 73% of panels recommend 7 to 8 years of endocrine therapy. Then in the third case, 3 lymph nodes are positive. The responses shift even further toward extended duration, with over half of the panel favoring 10 years. And another 46% actually select 7 to 8 years, that is only 1 or 2 years less. So, but in the second case, with no negative but high genomic risk score, such as recurrence score of 28, the majority supported extending therapy. 45% recommended 7 to 8 years, and 17% opt for 10 years. Although there is no real data to support this, but I think the panels, or probably most of you, will use the recurrence score or the number of lymph nodes and positive or negative nodes to adjust the duration of the treatment from 5 years to 10 years. So this question want to know the role of anthracycline in non-negative patients. I think this is a postmenopausal woman with a non-negative T2 tumor grade 2, but with high genomic test. And about 3/4 of panels favor a non-anthracycline regimen. I think high genomic risk indicates chemotherapy, but it's a non-negative patient, so there is still concern of anthracycline. And so that's why the panels favor taxane only without anthracycline as for non-negative patients. So this also another way to adjust your adjuvant therapy according to recurrence score and nodal status. Now, if previous patient has one positive node, then the answer of the panel is different. Now you see that 85% of the panel recommend anthracycline in addition to taxane, even in a postmenopausal patients. But I need to remind you that lots of panels are actually from European country, and I think most of the European physicians still consider anthracycline is still beneficial for high-risk patients. Then this is a postmenopausal woman, but it's non-negative. But the recurrence score is 32. Still, 71% of panels favor anthracycline in addition to taxane over taxane only. I think Dr. Moon just mentioned about the recent San Antonio breast cancer update from the TELA-X trial. Patient with recurrence score larger than 31 had more benefit from anthracycline than from taxane only, from TC chemotherapy. So I think that's why about 3/4 of panel chose AC plus T. So if this postmenopausal patient is non-negative and T1 instead of T2 like previous, but this is a grade 3 tumor instead of grade 2, and the recurrence score is 32, and we see quite similar preference of anthracycline plus taxane. This, of course, reflects the TELA-X finding that for recurrence score larger than 31 remains prediction of benefit of anthracycline plus taxane. But individual factors such as tumor grade and treatment tolerance also will affect the doctor's clinical judgment. In this case, we have a 60-year-old postmenopausal woman with 3 positive nodes, but the recurrence score is 13. That's quite low. 71% of panels were not offered chemotherapy, even this patient has 3 positive nodes. So this finding is consistent with responder trial, which demonstrated that for postmenopausal patients with N1 disease, they will not gain benefit from adjuvant chemotherapy when the recurrence score was 25 or lower. Now, let's look at another nearly identical patient, same age, same tumor subtype, recurrence score of 13, but with 1 additional involved node, 4 positive node. Although there was a trial before, but that is not a randomized trial. So the responder trial only enrolled patients with 3 positive nodes. So we don't really have a level 1 evidence of data for lymph nodes more than 3 or say 4 or more. So 1/3 of the panel recommend no chemo, while 2/3 of the panel favor chemo, half for taxane TC 6 cycles probably, and half for AC followed by T. So I think this is because I just mentioned that responder only enroll patients up to 3 positive nodes. So this also highlights the ongoing tension between genomic profiling or biologic factors versus traditional anatomic factors like nodal involvement. So we need further study to guide us how to treat these patients. So let's move on to the adjuvant therapy for premenopausal patients. For non-negative patients, we have TELEX to follow. So for this non-negative patient with tumor smaller than 2 centimeter, grade 2, and with different recurrence score from 12 to 18 to 23. The voting patterns reflect the influence of recurrence score in tailoring treatment among our panels. So with a low recurrence score of 12, about 64% of panelists recommended tamoxifen only, and only 3% opting for chemotherapy. When recurrence score increased to 18 and then 23, there is a shift from tamoxifen only to ovarian function suppression plus AI, and then toward chemotherapy. So with a recurrence score of 23, 56% of panels recommended chemotherapy followed by endocrine therapy. This illustrates how genomic risk influences tailoring of adjuvant endocrine and chemotherapy in premenopausal non-negative patients. Now, let's see the premenopausal patient with 1 positive node. With a low recurrence score like 12, 39% of panelists already opt for chemotherapy. This is quite different from the 3% in the non-negative setting we just mentioned. And about 60% of the panel chose ovarian function suppression plus AI or tamoxifen. This indicates most of the panel consider low recurrence score indicates no benefit from chemotherapy or they are more endocrine responsive. Although responder trial does not demonstrate that no positive premenopausal patients with recurrence score of 25 or lower still get they actually still get some benefit from chemo. As the recurrence score increased to 18, we can see the choice of chemo rise to 67%, and by 23 recurrence score of 23, 82% of the panel recommended chemotherapy. So, you know that in the ASCO guidelines, they still say that there is no good assay to tell us whether or not to give chemotherapy for premenopausal no-positive patients. But in the real world, from the both of the panelists, you can see sometimes they will still consider genomic risk can help you to guide whether or not to give chemotherapy. This slide tries to explore how nodal status, recurrence score, and the Ki-67 impact our adjuvant treatment decisions in premenopausal patients with no positive disease. You can see with lower recurrence score like 12, few panelists chose chemotherapy plus CDK4/6 inhibitor. When the recurrence score increased to 18, more panelists chose chemo plus CDK4/6 inhibitor. This shows that even modest increase in clinical or genomic risk can lead to treatment escalation in no positive premenopausal patients. And in the final scenario, just one positive node, but Ki-67, 30%. CDK4/6 inhibitor-based therapy was chosen by the majority. This reflects the influence of Monarchy and Natalie trial. Both used Ki-67 larger than 20% as part of the high-risk definition for including patients in the adjuvant CDK4/6 inhibitors. So let's see how age affects the choice of chemo or not. For premenopausal patients with no positive disease, with an intermediate recurrence score of 18, 60% of panelists favor chemotherapy followed by endocrine therapy plus a CDK4/6 inhibitor if the patient is 31 years old. However, if the patient is 50 years old, then it's different. Less than 35% of panel chose the same aggressive approach, while a large proportion prefer endocrine therapy, including ovarian function suppression with or without CDK4/6 inhibitor. When Ki-67 was 20% in this 50-year-old patient, the response of panel is similar to recurrence score of 18, more for endocrine-based options, with only 40% choosing chemotherapy plus CDK4/6 inhibitors. Here, we see the treatment preference for 57-year-old postmenopausal woman with no negative and disease and oncotype recurrence score of 25. Nearly 80% of panel chose AI with or without CDK4/6 inhibitor, which means most of panels follow TERA-X that recurrence score of 25 does not indicate chemo. Among the panelists who choose endocrine therapy, half of them chose CDK4/6 too. This is probably because in Natalie trial, they included no-negative patients with high genomic risk. Although the definition of high genomic risk in NATALI trial was recurrence score of 26 or above, as recurrence scores are continuous variables, many experts probably consider it will be too much to offer chemo, but try to add on CDK4/6 inhibitor with not inferior efficacy, but better toxicity. So that's the trade-off between chemotherapy and or CDK4/6 inhibitor. You probably know that there is a right choice trial for metastatic breast cancer to demonstrate that for metastatic breast cancer patients, CDK4/6 inhibitors and chemotherapy has about the same progression-free survival. So this voting reflects the uncertainty about whether recurrence score of 25 alone warrants escalation of treatment in non-negative disease. So now this is a final slide that summarizes how nodal status, Ki-67, and recurrence score together influence the decision of adjuvant therapy in postmenopausal patients. For a non-negative case with high recurrence score of 26, 62% of panelists chose chemotherapy, followed by AI. But for similar case with 26% of Ki-67, only 40% of panel chose chemo. This corresponds to previous Sengelen consensus that 30% of Ki-67 may indicate adjuvant chemo. In contrast, for patients with 1 or 2 positive sentinel node, but much lower recurrence score and Ki-67 values, around 50% of panel favor AI combined with CDK4/6 inhibitor rather than chemotherapy. So in summary, even in patients with increasing nodal burden, low recurrence score, and low Ki-67 continues to guide many clinicians toward de-escalation, favoring AI plus CDK4/6 inhibitor over chemotherapy. Here are the key takeaway message from the Sengelen International Consensus this year. So 5% is probably the accepted chemotherapy benefit threshold on distant disease-free survival for ER-positive, HER2-negative breast cancer patients. And extended endocrine therapy is supported as nodal status and the genomic risk increase. Nodal status can outweigh toxicity concerns, often leading to more intensive regimens, including anthracyclines. In non-negative high genomic risk patients, here recurrence score larger than 31, there is increasing preference for anthracycline plus taxane over TC regimen, reflecting the confidence in anthracycline efficacy as supported by the TELEX subgroup analysis presented in San Antonio Breast Cancer Symposium last year. Even with nodal involvement, clinicians are inclined to de-escalation if recurrence score and Ki-67 are low, favoring AI plus CDK4/6 inhibitors over chemotherapy. Thank you for your attention.